Hi there, my name is Vic Veer. I'm an ENT surgeon working for the NHS in central London. A lot of people, when they think about snoring and sleep apnea surgery, think about a UPPP, and I'm not even bothered trying to say it. It's just down here. Now, no one really does this operation anymore, and there are a lot of good reasons for this. The first reason is that a lot of people who do or used to do UPPP realize that actually the most effective part of that operation is removing the tonsils. And there's loads of good evidence about removing grade 3 and 4 size tonsils and improving sleep apnea, even 2, 3, 4, actually, there's data on that. But the reason why we don't do UPPP anymore is that it causes problems sort of 3 to 5 years after the operation. You have to come back for another operation. And what I want to do is quickly describe why that seems to happen. Now, there are lots of little variations about how people do a UPPP. But in general, you take out the tonsils and then you cut around the excess tissue, and sometimes also you remove the uvula as well. And then with that raw area all the way around the free edge of the palate and the fact that your tonsils have been removed, you then go and stitch up those two edges together to leave you with this sort of upside down U shape. It works quite well in the first few months. And then with time, you'll notice that actually it doesn't work quite so well. And what I mean by that is the palate's meant to be there to flap forward and flap backwards. So if it's comes forward, it sits in front of your tongue, it allows the air to come through your nose so you can breathe through your nose naturally, assuming that you don't have a blocked nose. If it flaps back, the idea behind that is that you can drink water and it will go down the right way. It doesn't come shooting out of your nose instead. Or food doesn't get stuck in the back of your nose in the area of your nose. Hope you heard that, but you know what I mean. Back there where your adenoids are. Now, if your palate isn't working properly, or if it gets stuck, like in one of my videos about nasopharyngeal stenosis, then you really feel it. You really realize how important the palate is. So I don't particularly like UPPP. I don't think I've ever done it in any of my own patients before, because what I'm trying to do is not cut away at the muscles that are going around the free edge of the palate. Getting rid of redundant tissue, extra sort of flappy bits of skin that are there, is fine. But what you mustn't do is do your stitches or leave the scar tissue around the free edge of the palate. Because when you're doing sleep surgery, the most important thing is to understand how scarring works. Scar tissue is really useful for us because, I mean, I could just remove the palate, remove everything and leave you with a big open space, and I'm sure you won't have sleep apnea. But the problem is you won't have a very functional throat either. So we use scar tissue rather than cutting things out of the throat and leaving you with abnormal anatomy. We use scar tissue to bring you back to a more normal position. And the reason why I'm doing this is because scar tissue contracts with time. So if I remove the skin from the inside of my arm here, initially it would swell up and get infected looking. You have to keep it clean and it would be a real pain to look after. Then the skin would grow over and it'll still be red and raw a few weeks later, and it'll be swollen and not very nice looking. Eventually it'll turn into a big red area in this here, and it'll still be quite swollen, but slowly it'll settle down to a relatively normal sort of shape sort of skin. But 3 to 6 months later, that area will turn into a white knobbly scar. It will shrink and contract in. So you'll get this sort of contraction of the skin, and it looks tight and it feels hard to touch. That scar tissue is really useful, and the contraction as well is very useful because it pulls tissue together. Now, in snoring surgery and sleep apnea surgery, I often use scar tissue and its method of contracting to open up the throat. What you don't want to do is make it close it down. Now, if you look at the image, which hopefully I would have drawn here, if you're doing scar tissue like a rim of scar tissue around here, yes, initially it'll be firmer, it'll be harder, it'll feel tighter as well. You've cut through some muscles, but it doesn't really matter. But the problem is, in 3 or 4 years' time, that contraction, you can see it will just shrink down like this. And that will make the air passage hard to get air back and forth from your mouth, through your nose, all that sort of area. It becomes less able to work. And then it also, with time, softens up as well. So it doesn't stop the snoring either. Another thing to worry about is that the more you nibble away at the palate, the higher it gets, the less soft tissue you have relative to what you used to have or what a normal person should have. It means that even if you tried CPAP, because you say, like, I give up on this surgery thing, I'm going to try CPAP. You put CPAP on, it blows air through your nose typically, but the problem is it'll come straight back out because the airflow is better coming forwards because there's not much palate there to for the palate to drop onto your tongue so it goes down into your throat. It just does that. It misses the top of the tongue, so the air comes out through your mouth. It just passes right through like that. That's why, although nasal pillows are quite useful, you just get air flying out of your mouth. So the air is just circulating around like this and not actually getting into your lungs where it should be. So there's lots of problems about changing the way palate functions and the anatomy of the palate. Do not do a UPPP. That's why lots of people don't do UPPP anymore. You know, the few surgeons in this world that are interested in snoring sleep apnea just don't do it anymore. Anyway, I hope you found that useful. I'm going to go on to my next video now. Bye-bye.